Hello everyone, my name is Akang Shrinani, and welcome to my YouTube channel Neuro Chat with AG. On this channel, I plan to cover topics that are closest to my heart and support the neurodiverse community. Topics related to neurodiversity, autism spectrum disorder, and more. On the channel, I will interview thought leaders, esteemed researchers, scientists, professors, doctors, and psychologists, seeking their views and updates on their latest work, research, etc. I will also chat with parents of neurodiverse kids and adults and talk about experiences of neurodiverse individuals. Dr. David J. Cox is the Vice President of Data Science at Rethink First, an academic researcher and a data technologist. His expertise lies at the intersection of behavioral data science and artificial intelligence, mathematical and computational models of behavior, clinical ethical decision-making, human choice dynamics, and health economics. Dr. Cox's expertise involves leveraging data to drive meaningful outcomes and applying advanced data science techniques to improve the efficacy and research of interventions, particularly in the areas of autism and behavioral health support. He is a co-author of the books Practical Ethics for Effective Treatment of Autism Spectrum Disorder, Statistics for ABA Practitioners and Researchers, and co-editor of Research Ethics in Behavioral Analysis, From Laboratory to Clinic and Classroom. In addition to these books, he has published more than 50 articles and book chapters, spanning across applied ethics, ethical decision-making, quantitative analysis of choice and decision-making, verbal behavior, and artificial intelligence. Mr. David, welcome, and thank you very much for the time today.
Oh, thanks for having me, Akang. It's great to be here.
And to jump right into it, could you tell us a bit about your journey and how you got involved in behavioral health?
Yeah, sure. So it really started during my undergraduate years. I was out at Arizona State University. At the time, I was pre-med, so a psychology major, but pre-med, looking to go to med school, and just trying to find any kind of job related to mental health in any capacity to make my resume look better for when I apply. And when you're an undergraduate, there's not many jobs that you can get in mental health directly, but I did find one working as an in-home therapist for individuals with autism spectrum disorders. And so that's really what got me interested and started becoming knowledgeable about this field generally. Immediately fell in love with what we were doing to help these individuals, both from a kind of scientific therapeutic standpoint as behavioral health therapy, but then also from the kind of personal side of it, just seeing how you could go in and have this positive impact on kids' lives by working with them directly and helping teach them to their unique kind of learning styles and whatnot. So did that for about 8-10 years, worked clinically, became a board certified behavior analyst, had a caseload. And then after that, really, so I kind of got started in behavioral health. After about 8 years, I got more interested in kind of that clinical decision making. How can I, as a clinician, know that I'm making the right or the best choice for each one of the clients that I was working with? And that took me down a rabbit hole of research and academic workings on choice, judgment, decision-making, things like that. And that's where I went and got my PhD in behavior analysis, really focusing on kind of choice and decision-making. And I'm sure we'll talk about this later on, but that's also where I started getting interested in artificial intelligence, machine learning, and how that we can use that to help us make better decisions in these clinical contexts. But yeah, early on, it was just looking for a job, happened to fall into it, kind of fell in love.
Awesome. And could you talk about your work and how you applied data science to behavioral health?
Yeah, absolutely. And so during the PhD program, I was really getting into these mathematical models to help us understand why people make different decisions that they do in their daily lives. And at that same time, this was the mid 2010s, a bunch of research was coming out where, you know, AI is better than doctors at diagnosing cancer, and AI is better at doctors than doing X, Y, and Z. And so I was immediately intrigued and thought, like, wait, how is this technology doing what I want to be doing, right? Improving judgment and decision making, but in a manner that's better than what humans can do. And so when you kind of get to the root of that, essentially what you have is a lot of data on this healthcare context, this one decision that people are making. And from that data, you can run these large algorithms that help you tease apart the nuance and the complexity of these data sets in a way that's hard for us as humans, right? Because we can't think of all things or consider all variables at one point in time. And so that's really kind of now what I do with data science and behavioral health today is kind of just mimicking what's been done in other areas like cancer diagnostics or examining x-rays and things like that. But for behavioral health, how can we take all this data we have about individuals, the therapy that they might be receiving, and through that provide some kind of decision supports for the clinicians that are out there doing all that hard work.
And what do you think the primary challenges are in applying data science to behavioral health, particularly in areas like autism support?
Yeah, I think there are kind of two. So the first area I would say is access to data. Though a lot of behavioral health therapies have a decent amount of data, we often don't collect the same types or amounts of data that you might see in physical health, right? So for example, if I'm trying to diagnose cancer in an x-ray, I probably have a backlog of a bunch of images where I know cancer or not, and I can use those data to create algorithms. In behavioral health, really the target there is someone's behavior, right? How they're going out and moving about their daily lives. That's really hard to get data on. We might be able to get people to perhaps sit in a room, tell us about it 15, 20 minutes a week, but them telling us about what's going on isn't the same as the actual data that's going on in the environment in their daily lives. So the big challenge really is, can you get the data that you need to generate some kind of model building, create artificial intelligence that can help in that kind of clinical decision process. The second area I think that we've run into a lot really is in the practitioner, the clinician acceptance of these technologies. I know from my own personal experience, because I got into the clinical wing first, we're not trained in the clinical capacity to really appreciate the mathematics, the computer science, the IT infrastructure that's behind a lot of these technologies. And so when someone's coming out and saying like, hey, I have this thing that can help you do your job better, you immediately are like, well, all these kind of questions pop up. But that trust and that buy-in for people to even just look at the tool, think about how it might help them in their daily lives can be challenging, because we're just not taught to evaluate technologies in these ways.
I assume like bias would play like a huge difference. Like, when you're asking people about like when collecting the data, like, their bias about like, how bad a situation was like in retrospect.
Oh yeah, absolutely. And it's a really interesting system, I think, in many different ways. So like one, which is kind of perhaps where you're leaning, is this idea of selection bias. So that is, the people that are end up in therapy for whom we even have the opportunity to collect data is a subset of the population that might be living with some kind of diagnosis or condition or whatever you have, but it's reached a level that they're seeking help, right? So as soon as you're trying to differentiate perhaps typical or non-clinical patterns of behavior from those that are exist such that people seeking help in some capacity, we're already playing with kind of a biased subset of the data in and of itself. Then on top of that, you also have, especially with a lot of data privacy and security laws and things like that, you as an individual in the healthcare system have the right to not have your data used on these algorithms. So you also have this interesting scenario where it's, a subset of the total population is even available for data. Then you have a subset that may or may not be giving data that's perfectly accurate with their life, plus an even smaller subset that are saying like, yes, you can use my data in these algorithms and whatnot. So what we have to play with on the back end is much smaller than the total existence of the population as a whole. So it creates some interesting challenges, but I don't know. I think data privacy and security is a good thing to have. So it's a good problem to have to try to work around.
Given the complexity and heterogeneity of autism, how do you account for this when building models and avoid one-size-fits-all solutions?
Yeah, so I think what's really fun coming from the clinical realm is, although if you think evidence-based practice, doctors, behavior analysts, speech language pathologists, psychologists, they're taking studies that have randomized controlled trials, right? These package interventions. And that's what they choose from, if you will, to then use with their clients or their patients. But as a clinician, as a practitioner, they're all kind of tweaking and changing what those interventions look like based on how you as an individual respond to therapy, right? Think about doctors who are constantly tweaking your drug dosage up and down, or maybe trying different things. So in that same vein, clinicians are used to individualizing therapy to an individual based on how they kind of respond to treatment. And we do the same thing in data science. So we have these big data sets, and the goal really is, if you have enough data, can I get down to modeling and creating this like individual person level or this individual level model that's really taking into account that person's life circumstances to make these predictions and whatnot. To the extent that you don't have that data, you can play around with things called like patient clustering or patient grouping. So that is like, rather than treat all individuals with autism as one big group, right? We find ways using artificial intelligence to say like, oh, all of these individuals are similar to each other along these, 100 dimensions. And these ones are similar to each other and these, so on. And then you can build models kind of within those smaller cohorts or groups or clusters. But again, we maybe start big if the data requires us to do so, but we're always driving towards that individual level modeling, just like a clinician would be when they're practicing whatever kind of physical or behavioral health.
How do you navigate the ethical implications of using AI and machine learning in behavioral health, particularly when it comes to issues like bias, transparency, and patient privacy?
Yeah, this is a great question. So patient privacy is relatively straightforward, which is kind of nice, right? We already have laws around HIPAA, GDPR, if you're over in the United Kingdom, and so forth. And there's a lot of laws and regulations, and IT infrastructure has figured out how to be compliant with data movement, transportation, making sure it's anonymized, adhering to a lot of these legal guidelines. So that's kind of nice. The other thing that I'll note is, and maybe kind of playing in parallel with that. So we have historical methods for handling data privacy. The same kind of exists for transparency and biasy. And what I mean by that is, so historically, if you look at the bioethics movement of the 1970s, patient autonomy really came forth as the most important thing, right? That is, as a patient, you have the right to determine what happens to you clinically. So this opened the door for all sorts of things around informed consent or assent, and things like that, where essentially you're engaged in this conversation with your medical provider or your behavioral health provider to come to a joint decision about what should happen, right? And within that, they have to be open and honest. Here's everything I know about your condition, or whatever the assessment procedures were. Here are the treatment options. Here's why I think you should do something rather than something else. And so similarly in data science, where doctors maybe used to have those conversations with clients, we're now kind of having those conversations with doctors, right? So I'm going in and saying, hey, doctor, or hey, behavioral health provider, here's our total data set, right? Here's the type of patients or clients that went into it. Here's what these algorithms and things are really good at. And at the end of the day, we're kind of working with that behavioral health or that physical health provider to get their consent or their assent, right? Do they trust it enough? Are we transparent enough that they say like, yes, I'm going to use this now in my clinical practice, and whatnot. So although how we do that, how we're transparent may differ, really that kind of functional process is kind of the same. The one downside, or the one thing that I think is a little bit trickier right now in this space, is that we can create some kind of tool or technology or algorithm and work with the physician or with a behavior analyst and using that in their practice. But we also often don't talk directly with the clients or with the patient. So it's harder for us to know what their consent process and assent process looks like as they use these tools then in their practice. Ideally, they're also saying like, hey, in their informed consent process, I'm using artificial intelligence or these other clinical decision aids to help me do my work. Just letting you know, or like, here are the potential outcomes. Like, do you agree with that? That's part of the treatment process. Yes, no. And kind of work that in. In terms of bias, we can kind of follow the same idea where there's existing methods for thinking about this that we really can carry over into our data science work. So for example, if you look historically in the literature of healthcare generally, there's things like racial bias that pop up, gender bias, or as a clinician, cognitive bias, right? Or these suboptimal decision making and whatnot. And there's been a number of methods that have been developed to try to capture that. And there's a whole field called quality measurement that really focuses on this. So here, there's the movement around like social determinants of health, trying to run analytics to know, are we seeing different patient outcomes or different client outcomes based on race or gender or some of these other things. And these techniques really allow you to diagnose or understand where bias might exist in what you're doing. And in data science, we essentially can do those exact same kinds of things, right? As I'm building my models, right, all the data that I'm bringing in, I can start checking it to see, are there certain groups that are over or underrepresented in my data set that's going into it, which then we should be transparent about on the back end. And then when I create these models and they're starting to make recommendations or provide decision supports or aids, we can also do those same checks. Am I making different recommendations for individuals of a certain race or a certain gender? And then often what should be done is you do things that are called ghost deployment. So that means as I, create this model, I don't just put it out into the clinical space straight away. Rather, I start running it and running these kinds of evaluations and checks. And I start to understand like, oh, shoot, we're making a mistake here. Great, let's go back and fix it. And you make sure that to the best that you can with the data that you're not seeing any biases in what's going on. And then only then would you put it actually out into clinical practice for people to interact and use.
What has been the most unexpected insight or outcome from your data-driven work in autism and behavioral research? And how do you think it kind of changed how you approached and thought about your future projects?
Yeah, I really like this question. So when I got started back in the day, during my undergraduate years, there was some research on this idea of clinical decision making, but really, and for the main point that was really exciting, one kind of assumption was that all kids, more hours of behavioral therapy is always better. And it kind of makes sense at first glance, right? You're like, oh, I guess, if you're working with someone to help them learn, the more hours you spend helping them learn, the more progress they're going to make. But this was really, I think, an inherent assumption to a lot of the work that we were doing. And one thing that's kind of popped out when we can start using AI and some of these more advanced techniques was this idea of a dose response curve. And it really comes from behavioral pharmacology. And the basic idea you can imagine is, let's say I measure your behavior when you don't have any medication in your system, right? And I kind of graph that. And then I give you, say, more and more of some kind of drug that I'm giving you to treat, I don't know, antibiotics, right? I'm trying to treat something. The more drugs that I give you, the more therapeutic effect that you have, but it kind of asymptotes at a certain level. And more of that drug doesn't really have any additional benefit. What was surprising for me when we started playing with AI and data science and behavioral health was we were seeing these same kind of dose response curves for behavioral health therapy for individuals with autism spectrum disorders, suggesting that, more hours isn't always better. And then another kind of fundamental concept from behavioral pharmacology is that those doses where you reach that kind of maximal effectiveness is different for you because of your biology compared to me because of my biology and compared to my wife because of her biology, right? So though we see a dose response curve, the shape of it changes based on the individual, based on their unique situation. Same thing we were seeing with these dose response curves in behavioral health. So I think that was kind of the big kind of eye-opening thing to me was there was this kind of fundamental assumption that I was making as a clinician that turned out to be not quite right. Most kids, we see this dose response curve, but it differs for everyone based on kind of what they're learning, how they're learning, who they're working with, things like that. And then in terms of shaping future projects, really what it's done for me is caused me to go back and think, how many of these clinical assumptions or this kind of clinical lore exists out in behavioral health therapy? And how can we use data to start understanding when these assumptions might be inaccurate or when they might be justified? So for me, it's been quite humbling, I think, just recognizing the many assumptions that exist. And it's been fun to take a closer look at those and see which ones are right and which ones are wrong and try to do better moving forward.
Yeah, thank you.
Yeah.
And can you discuss a specific instance when you had to tailor a data science approach to better meet the needs of the behavioral health community, particularly in the context of autism support?
Yeah, this is an interesting one. And I think I'm fortunate because I started in behavioral health and then kind of came into data science and artificial intelligence. So from the beginning, I've always really thought about everything I've done kind of through that lens. But here's, I think, a really interesting point for all the data scientists or AI colleagues out there that might end up listening to this. And there's often this Venn diagram that's used to talk about data science, right? You need, mathematical and statistics skills, and you need computer science skills, and then you need domain expertise skills is often kind of that third bucket. I came from kind of that domain expertise and expanded out, but without having that in a kind of a robust way, I think many of the approaches that I may have been taking would have been inaccurate, or I would have been making assumptions, kind of like I mentioned before with the clinical work, that could have biased my models in ways that didn't really make sense based on what we know about how behavioral health therapy works and how people learn. So for me, kind of the big takeaway has been really the importance, first and foremost, of that domain expertise. I think a lot of people are great with math and stats. A lot of people are good with computer science. But if you don't have that kind of critical domain expertise on your team, it's really easy to do this stuff poorly or to introduce bias that you don't even know you're introducing just because you're not familiar with the field.
And could you share a case where advanced data science techniques led to a breakthrough in understanding or supporting individuals with autism that traditional methods might have missed?
Yeah, definitely. I think there are kind of three here that stand out when I look at the literature. One goes back to kind of the hours recommendations and dose response curve that I mentioned. I think that was something, had we not had the data set and the more advanced analytics in place, never would have uncovered that. I think I would have just continued to assume when you recommend hours of therapy, that more hours there are always better. A second really important one, though, that I think is exciting is a lot of the speech to text technology around speech recognition. And there's some really interesting technology and tools coming out now, not necessarily specific to autism spectrum disorders, but just to individuals that may have speech intelligibility challenges. That's making it easier for what they say to be conveyed into text that then allows them to communicate with others more efficiently. So historically, without this technology, a limited number of people, a handful, may have been able to understand what someone was saying just because you had to really get to know the person. But now with these tools, with some of these more advanced speech to text technologies, that person can now interact with a greater number of people in their community, which I think is incredibly fantastic. And then the third area that's coming up in the last year or two that's pretty exciting is earlier diagnosis of different behavioral health patterns and whatnot, including autism spectrum disorders. And so this is fantastic because, the sooner we can identify that someone might need additional help, the sooner we can get in there and help that individual, which is benefits, a lot of these things compound over time. So the sooner you can get in and help people, often the better. But that's another area where advanced analytics and AI is, I think, making some really cool headway.
And what role do you see for emerging technologies like deep learning and natural language processing, which you kind of mentioned, in advancing the field of autism support and behavioral health?
Yeah. So deep learning is really good, or involves a set of techniques that are really good at identifying patterns and relations in the data. So three areas, or two big areas, I should say, that I think deep learning will continue to help us out. One is this idea of complexity and dynamics. So kind of like you were saying before, or asking about kind of that individual tailoring and things like that. If I really want to understand the complexity of like your entire life or my entire life, I'm going to have to know or handle a bunch of data, understand the complexity and the relations in that, and then also how it changes dynamically in time. And so I think deep learning generally allows us to understand human behavior at a more fundamental level than we perhaps might have before. And then the second level, which is I think the really exciting practical applications, gets at that kind of individual level modeling. So some traditional techniques, they can be a little bit harder to identify the kinds of patterns that I would need to help somebody at that more individual level. But deep learning can help us, I think, get to that individual level modeling more quickly. But I will say there's a data challenge here. Deep learning is notorious for needing a lot of data to do well what it does. And so I think that'll be another concern that kind of runs parallel, is like, how do you get the data to actually run these things if you're interested in complexity, dynamics, and that individual level. For natural language processing, I think it really is some of the stuff that we already kind of talked about with the speech to text technology. And, if you combine that with this individual level modeling idea, I imagine this not too far into the future, we'll have these tools that allow us, or maybe I'll take a step back. Already today, right? Or maybe I'll take even a further step back. When I was your age, if I were to have gone to, say, Italy and just like start walking around, I would have had to go through all the effort to learn Italian, to actually speak with those people and converse with them. Now, when I go over there, I can just hold my phone open, right? And I can use Google Translate, and it may not be perfect, but I can communicate with somebody. I don't speak their language, they don't speak mine. And in real time, we can converse with one another in a meaningful way. Going back to kind of what we were saying with this idea of speech to text technology, and especially where you look at some individuals with autism that may have a different method or modality of communicating, you can imagine this universe in the future where it's less effort for them and less effort for you and me to understand what they're trying to say or communicate and to interact socially, because we have these tools that can translate their behavior to something that makes sense to me, and vice versa. So that's where I think NLP techniques, especially as it relates to autism support and behavioral health, can be incredibly useful, because it allows us to extend communication in ways that are much easier to do in terms of crossing any kind of bridges or barriers that exist now. Whereas historically, we would have to take the time to learn how to communicate with somebody based on all their nuances. Technology hopefully will make it easy. You just put in a little earbud and it translates it for you, and everything's beautiful.
Dr. Cox, I want to extend my sincere gratitude for the time you spent with me today. Your expertise in leveraging data science to drive meaningful outcomes in behavioral health and autism support is truly impressive. The applications you mentioned for all these academic researches and practical applications is inspiring. And your vision for the future of data science and behavioral health is very exciting to me as well. So thank you for sharing your valuable time and insights.
Oh,
Thank you so much.
I really appreciate you having me, and I appreciate that you have this channel and the work that you're doing.